شكرا جزيلا. I have the honor to present our dear colleague, Professor Shamaa Absattar. She is our reference for pediatric radiology by the mean in Ain Shams University, not only for the pediatric surgeons. If we have any difficult case, we assign her by name. We don't say we need a second opinion. We need Dr. Absattar opinion. She's going to talk for us about the MRI defecography in children and adolescents. Please, Doctora.
Thank you very much, Dr. Osama, for introduction, and thanks for invitation. I will talk about MRI defecography in children and adolescents, and this topic is rarely written in literature. Most of the papers discuss this topic, especially in older females or adults with chronic constipation, and I will talk about our experience in Ain Shams University. I will talk about MRI anatomy of the pelvic floor, indications of MRI defecography, its technique, and finally case demonstration of various pelvic floor disorders encountered in Ain Shams University. Pelvic floor anatomy, as we all know, starts with the levator ani muscle, is the main muscle of the pelvic floor. It's formed of various subdivisions. Puborectalis is the main muscle of the pelvic floor surrounding the rectum and the anorectum, and iliacossogeus muscle in here in light green. Puborectalis is in dark green, and pubococcygeus in also surrounding the puborectalis. And regarding the MRI anatomy, this is a sagittal T2 weighted image. This is sagittal T2 fluid in lunar bladder appear as bright signal, and this is rectum and anal canal here, and this is various muscular subdivisions. This is the external anal sphincter here, and this is the puborectalis, and this is the levator plate. In axial section, we can see here the anorectum here, surrounded by the puborectalis muscle inserting into the symphysis pubis. Also, this lower down at the level of the ischial ramus, we can see the anal canal, and this is the transverse perineal muscle here. In the coronal plane, this is the iliacossogeus muscle. In number 4, this is the iliacossogeus, and number 6 is the transversus perineal muscle. Number 2 is the rectum, and number 1 is the anal canal. MRI defecography indications difficulty of rectal evacuation, incontinence, pelvic floor pain, or bleeding per rectum. Patient preparation, the child should be cooperative, usually above 8 years of age. No specific preparation apart from those related to general MRI examination, explanation of the technique to the patients and the guardians, and finally injection of rectal gel after acquiring the basic sequences. This is the static images before injection of the rectal gel. We can see here the sagittal, coronal, and axial sections to demonstrate the MRI anatomy of the pelvic floor muscles and figuring out any abnormalities or any mass lesions present in the pelvis. Also, the static images are acquired after intrarectal gel injection in the same planes, sagittal, coronal, and axial sections. Also, axial stair T2 fat suppression sequence and axial T1 are acquired to demonstrate any associated or characterize any associated pathologies that could be encountered. Dynamic images, classically speaking, are acquired at rest and squeezing with doing Kegel maneuver and during straining or valsalva and defecation. But actually in children, especially in young 8, 9, 10 years old, which are the common patients in our unit, can differentiate or can understand the differences between these stages. So I mainly rely on the defecation or evacuation phase. This is a dynamic image. I comment on the degree of squeezing by, or the patient elicits the acquired pressure by seeing the bulge in the anterior abdominal wall. This is at rest here on the left, and on the right-hand side, we can see it during defecation. We measure the anorectal angle. This is at rest by measuring the angle between two planes at the one at the posterior rectal wall, which touches the levator ani, and the other line passing through the mid-axis of the anal canal, and normally the anorectal angle widened during defecation. The other planes are the BC line, bubococcygeius line, and we measure the descent of the anorectal junction here below the BC line. It's normally the M line normally below 2 centimeters in adults. This case it is 8 years old. We can see here elongation of the M line denoting pelvic floor descent. Also the hiatal H line, this in green here, measuring the pelvic floor hiatus. It's measured at rest and see how much changed during defecation. It's normally equal 5 or less in adults. So to understand the age variability, we measure the hiatal PC ratio to have a number we can compare among age groups. It's normally about 50%. I will show you a case demonstration. This is the first case. All cases are done in our MR unit. This case, 8-year-old girl with chronic constipation. During defecography. We can see here the patient is unable to expel the rectal gel due to non-relaxing anal canal. We can see here also the anorectal junction. The anorectal junction here, there is no descent of the anorectal junction or abnormal widening of the pelvic floor hiatus, only non-relaxing anal canal. Another case, 6-year-old boy complains of constipation. The patient also there is squeezing with no expulsion of the rectal content. These are the various stages of the cine images. At the beginning, as a rest, no descent of the anorectal junction. However, during defecation, there is descent of the anorectal junction here with non-widening of the external, non-relaxation of the anal sphincter here, and finally the patient's the anal canal widened and part of the rectal gel is expelled. We can see here non-relaxing of the puborectalis mali exerting a bulge on the anorectal junction. Also, there is a pelvic floor descent of the anorectal junction, defined as descent of the anorectal junction greater than 3 centimeters below the BC line. Also, there is laxity of the levator ini demarcated by vertical orientation of the levator plate. Another case is 13-year-old boy with chronic constipation. At the start of defecation here, there is a partial expulsion of the rectal content, but with marked descent of the anorectal junction. Also, finally, there is these are the various stages here with descent of the anorectal junction. Partial emptying of the rectal content. We can see here interception and urethral hypermotility. I will show the magnified view. We can see here in yellow there is urethral hypermotility, abnormal posterior and inferior rotation of the urethra. Also there is interception in green and non-relaxation of the external anal sphincter. Another case is a 15-year-old boy with bleeding rectum at the end of defecation. Colonoscopy reveals a rectal ulcer. In static images after rectal gel injection, we can see here thickening of the left lateral aspect of the rectum and anal canal. And this is during defecation here. Also, there is a partial expulsion of the rectal content with descent of the pelvic floor. Here is a static image, these shots of the cine images. We can see here the constellation of urethral hypermotility with interception and the rectal pelvic floor descent in the presence of inflammatory process and rectal ulceration that makes the diagnosis of psoriatic rectal ulcer syndrome, which is a well-recognized diagnosis that describes a combination of rectal prolapse and functional pelvic floor abnormality. The name actually is misnomer since it's a single ulcer is present in only 20% of cases. And actually, there is maybe multiple ulcers present in 40%, and the remaining cases display other morphologies, including polypoidal masses and no ulcers at all. The last case is an 18-year-old patient with anorectal anomaly. It was a rectoperineal fistula, underwent anoplasty at birth. However, he complains of constipation and soiling. This is the static images showing sagittal T2 weighted image. We can see here buckling of the muscles behind the rectum, along as the anal canal, behind the anal canal, along with marked fibrosis here. And the axial sections, we can see the anal canal is anterior to the transverse perineal muscle, along with post-operative fibrosis. This is the dynamic image. We can see here the patient is partially evacuating the rectal content with descent of the anorectal junction. This is a shot of the cine images. We can see here descent of the anorectal junction and pelvic floor descent. Actually, this is a very nice demonstration of the previous hypothesis we hypothesized on 2014. This is a case of anterior ectopic anus. This is a case of anterior ectopic anus in yellow, and the arrows, white arrows, demonstrate the direction of action of the the sphincteric muscles. When it contracts its normal scenarios, it would shorten and pass along the course of the anal canal. However, in case of anterior ectopic anus or anterior misplaced anus, it works against the axis of the anal canal, leading to its obstruction, as happened in this case. This is a normal anal canal during normal situation. The direction of force of the muscles is along the anal canal. However, in cases of anterior anal displacement, it works against the direction of the anal canal, which causes obstructed defecation. I will talk about one more thing. It's a dyskinetic puborectalis here. It's a normal contraction of the puborectalis causing anorectal angle. This is from the literature of an adult patient, causing narrowing despite obvious signs of attempt of defecation and in conjunction with delayed evacuation. This is dyskinetic puborectalis. To summarize, obstructed defecation, we can see rectocele, descending perineum syndrome or pelvic floor descent, interception and rectal prolapse, spastic anal sphincter, as we can see, non-relaxing anal sphincter, or dyskinetic puborectalis, or solitary pelvic rectal ulcer syndrome. These are my references. Takeaway message: MRI is the ideal imaging modality for evaluation of pelvic floor dysfunction in children. MRI identifies pelvic floor anatomy and structural abnormalities at rest. Also, dynamic cine MRI demonstrates pelvic floor laxity during defecation and functional abnormalities. Thank you very much.
Thank you.